This is a plain CT KUB. First, I will discuss the findings on right side. Please observe that there is moderate hydronephrosis on right side. There is inflammatory straining of right perinephric fat. Right pararenal fascia is thickened. This one here. There are two calculi lying at the lower pole of right kidney. I go back again. This is renal pelvis here. It is dilated. Right ureter is dilated. Inflammatory straining of periureteral fat is also present. There is a calculus in the upper pelvic part of right ureter. It lies at the level of SV3, this one here. So this has resulted in moderate hydroureteronephrosis on right side. The inflammatory straining along the right ureter and perinephric fat are suggestive of the associated ureteritis and pyelonephritis. Now, please come on to the left side. Now there is cortical scarring at multiple levels. Cortex is thinned. There is moderate to severe hydronephrosis. Please observe this cortical thinning here. Renal outline is wavy. The dilated calyces, they are reaching almost the surface of the left kidney. This is dilated, slightly dilated renal pelvis. Left ureter is not dilated. So there is narrowing at left pelvic-ureteric junction. In fact, multiple surgical procedures have been done on both the sides. On left side, two calculi are present at the lower pole. Now, surprisingly, ultrasounds were done quite recently by quite qualified and experienced radiologist. Moderate hydronephrosis was given on right side along with calculi. Obviously, the level of right ureteric obstruction could not be picked up, but left kidney was declared as almost normal. No waviness of the renal outline and no hydronephrosis was mentioned on left side. Anyway, the calculi at the lower pole, they were mentioned by both the worthy radiologists. So one of the probable causes is that this, in fact, on left side, it's a sort of post-obstructive renal atrophy, cortical scarring and dilated calyces. So it is always advisable that to get optimum results, one should always do ultrasound with plenty of oral fluids, because if suboptimally dilated calyces are there, especially if there is post-obstructive atrophy, the dilated calyces may not be visualized to their best dimensions. But if a fluid overload is there, then dilatation of the calyces, it exhibits more clearly and one can better visualize the dilated calyces and of course the level of obstruction as well, because on left side there is no dilatation of the left ureter, so there is narrowing at the pelvic-ureteric junction, which has resulted in post-obstructive atrophy of the left kidney.